Hi, I'm Jonah Comstock, Editor-in-Chief at pharmaphorum. I'm here at ASCO in Chicago. It's day 3, and I'm joined by Peter Sasieni, one of the lead investigators on the Galleri trial of the GRAIL blood test for cancers.
Hello.
Thank you so much for joining me. I'm excited to do this interview because I've been talking to a lot of pharma folks and oncologists, and the topic of precision medicine keeps coming up. And this idea that, precision medicine is all well and good when you're coming up with new drugs, but if you don't know which patients have those mutations, if you can't find the patients, then it doesn't work. And so the diagnostic piece, the screening piece is so important, and that's what you've been working on, right?
That's right. We're trying to find cancers before they become symptomatic. It's always easier to treat cancers that are found in early stages, and so we're hoping that using the same sort of technologies which are being used in treatment, looking for minimal residual disease, we can find cancers earlier and early enough that it really makes a difference to patients.
And this was a trial that took advantage of the NHS in the UK and the scale that gives you, and you were able to enroll a pretty large number of folks, right?
That's right. So it's funded commercially by GRAIL, an American company, but we did it within the UK. And so we use the population database of anyone who is registered with an NHS family practitioner, which is essentially the whole population, to be able to invite people. And that was done by the NHS, so we didn't know who they were. And only if they said they were potentially interested do we get their details, and we could invite them. So we recruited 142,000 people that way. And then we were also relying on the NHS to actually make the diagnosis. So people who tested positive in the trial were referred by the trial nurses to an appropriate NHS clinic where they had to be seen within 2 weeks of that referral, and then they would go through the usual sort of diagnostic processes. And if cancer was found, they would be treated within the NHS as well.
So let's talk about the findings first, and then we can talk a little bit more about the test and the technology behind it.
Sure. So it was a randomized controlled trial, the only randomized controlled trial of a multi-cancer screening test that has ever been done. And the main outcome that we were looking for was a reduction in stage 3 and 4 cancers, so the advanced cancers. And that outcome was not met. We did not see a reduction. So it was 3 rounds of annual screening and then another minimum of another year's follow-up. And there was actually very similar numbers of advanced stage cancers in the 2 arms. It was a randomized controlled trial. But we did see a lot of the secondary outcomes in the direction that we would anticipate and we hoped for. So there was a significant reduction in stage 4 cancers, so the worst cancers. There was a 25% reduction in cancers presenting through emergency room, so in crisis. And they always have the worst prognosis, so it's a good thing to reduce those. And then when you screen, you expect to find more cancers, including more advanced cancers right at the beginning, because if someone enters the trial with an undiagnosed stage 4 cancer, it's too late to find it at stage 3. It's already stage 4. So all we can do is by screening, we find more stage 4 cancers, and it takes a while before that is balanced out because they become symptomatic in the control arm and catch up. And so what we saw was that we do indeed get an increase in stage 3 and 4 cancers in the first year, and then a decrease in years 2 and years 3. So that the fact that they are decreasing in years 2 and 3 is very encouraging, and it would suggest that in the long term, if you were doing annual screening for many years, we would see that reduction. And a reduction in stage 3 and 4 cancers should be good for patients in any case, but almost certainly it would lead to a reduction in mortality, cancer mortality too.
Now, this trial is over, or is it ongoing?
So it's ongoing in the sense that we will follow people up both for more cancers diagnosed over the next 2 years and for mortality, deaths from cancer. And there will also be additional testing of samples from people in the control arm. But the recruitment and the screening is complete. So as I say, we recruited 142,000 people in 10 months. They were randomized. and then they were screened. They had blood collections 3 times, and because we didn't tell people which arm they were in, so people came back at 12 months and 24 months. And in fact, 88% of the people who were recruited came back at 24 months.
And the control group was no screening or a standard of care screening?
So a standard of care screening for everyone, and the difference was that everyone had a blood sample collected on those 3 occasions, hopefully, and one group had that blood sample stored and the other had it analysed. If the test was negative in those who had their test analysed, they got exactly the same letter as the people who were in the control arm, and it said to them, yeah, thank you very much. There's nothing further at this point. That means you are either in the control arm or your test was negative. We encourage you to continue to have standard of care screening, and if you develop any symptoms, we encourage you to go and see your doctor promptly.
So tell me about the GRAIL screening. What makes it special? What's the technology kind of at work here that maybe we haven't had previously?
Yeah, no. So if you go back, 15 years, no one, I think, was thinking that you could have a blood test for cancer, for one cancer. And what's incredible is that there is a common signal for all cancers. So the technology is based on something very similar to now is often used in antenatal screening. So we're looking at the cell-free DNA in the blood, and in particular looking at the methylation pattern of that cell-free DNA. So when cells die, the fragments of the cells, including fragments of DNA, excreted into the bloodstream. The half-life is quite short, but nevertheless, if you take the blood sample and you get rid of the cellular material and look for the spin down the DNA, the non-cellular DNA. In the case of pregnancy, at the end of the first trimester, 12% of the cell-free DNA in the maternal blood is from the fetus, not from the mother. So similarly, if you've got a tumor, some fraction of the cell-free DNA in blood will have come from that tumor. And then, although it's targeted, it's looking at hundreds of thousands of sites and the methylation at those, and then it's using AI to distinguish between this is the signal, this is the methylation pattern that we think cancers have. And there's a lot of commonality for cancers at very different sites, very similar signals. And then in addition, the methylation patterns of DNA is organ-specific throughout the body in healthy organs. And so that means that the test is also able to say, if there is a cancer signal, where that cancer signal has probably come from. So there's a signal of origin. And that signal of origin was right in 92% of the cases where cancer was found with a positive test. So it really helps, because otherwise you're going to go, well, what are we going to do? A whole body PET CT or something? And so this is saying, no. It's probably colorectal, do a colonoscopy. It's probably a lung, do a chest low-dose CT scan. So it really helps the clinicians to make the diagnosis.
That's fascinating. Yeah, it's amazing what you can tell from a blood test.
Yeah, and they're doing pretty deep sequencing, so that you're actually looking for something like one part in 10,000 is what you're, one part in 100,000 even is what you're hoping to be able to see. But that means that we don't find precancers, and we don't really find absolutely tiny stage 1 cancers. But interestingly, there are a number of people who had a positive test when they came in and cancer wasn't found. And then some of them had a positive test on the second round and cancer was found. But there are even a few people who've had positive tests on the second round, cancer wasn't found, and then on the third round it was found. And the site of origin on the first round was exactly the same as where cancer was found. So there is something about it that not often, but very occasionally, we're finding cancers that are too small to see by standard methods.
So yeah, that suggests the potential for the technology.
So the potential is huge, but we did fail to meet that primary outcome. So it's not going to lead to screening programs being rolled out in the next few weeks. It's very positive, but it's a step away from mass introduction.
So what is the next step? An additional study or?
So, I mean, we will certainly be continuing to follow up these people and doing some more analyses, including analyses of the bloods from the stored samples in the control arm, so that we can look at it in more precision. Because if you have a negative test, it makes no difference. We didn't even know they had a negative test. So all the signal, if you like, comes from people who had positive tests. So we can get the answers with more precision by going back and look at that. I would like to see the test being used quite widely, particularly in people who are more deprived, at high risk of having an advanced stage cancer, maybe because of comorbidities, smoking history, obesity. Because if we have a screening program, we want to make sure that it works equitably and that we know how to roll it out across the country so that everyone benefits and that it doesn't cause problems to the healthcare system. So how will we be able to take bloods annually on millions of people? Will those referrals work well within the healthcare system? So I think we can be doing a lot of that, and also looking at different screening intervals. So in this trial, everyone was screened annually. There's a question of whether some people should be screened more often, every 9 months, every 6 months even, or whether others could be screened only every 2 years, which would make it
Based on risk factors, age, things like that.
Yeah, but also because we're going to be learning so much more from this trial about the natural history of cancers, so that there's very little known about what's going on before a cancer is diagnosed, because it's before the cancer is diagnosed, you don't really know what's happened. And so at what rates do cancers progress? At what point do they start shedding cell-free DNA so that it becomes detectable by a blood test like this? And I think, and then also, what is the interaction between the response to treatment and the extent to which they're shedding cell-free DNA?
That's really fascinating stuff. I'm sure we could talk about it for a long time, but it's about as much time as we have for the video.
Thank you.
Before we close out, anything you've seen or heard, any trends at the show that have been jumped out at you since you've been here?
So I think it's quite interesting seeing the sort of contrast in terms of what's expected from a new treatment and what seems to be expected from a new form of screening. And so there's quite a lot of negativity sometimes in the audience about screening tests, and they go, "Oh, but the sensitivity is only 50%. What about the 50% you're missing?" And it's like, well, you do a trial and you show you've extended median survival from 7 months to 12 months, and people are really excited, even though everyone's dead by 3 years. And it's like, well, why are we so resistant to making progress at a population level? And there are difficulties and there are reasons, but it seems to me that these technologies are making inroads across the cancer spectrum, from screening to diagnosis to looking for mineral disease to working out what treatments to give patients. And I think we need to think how to adopt them in rational ways that is really going to help healthcare or health and healthy life in the population.
Great. Thank you so much, Peter. Really great chatting with you.
Thank you. Lovely to chat.